Hi, good morning. My name is Kim Lakin from Hospital for Special Surgery in New York City, and I'll be speaking today on the pregnancy journey in scleroderma. So a few overarching themes. One, there's a growing body of literature demonstrating that there are improving outcomes for women with scleroderma who choose to become pregnant. And two, it is never too early to discuss pregnancy planning with your rheumatologist. So a few questions that we'll cover today. Does scleroderma impact fertility? What should be done prior to becoming pregnant? Will my scleroderma get worse during pregnancy? Will scleroderma impact fetal growth and development? Will scleroderma make my delivery high risk? And can I breastfeed if I have scleroderma? So first, the literature for scleroderma in pregnancy had generally been fairly limited. Many individuals with scleroderma are diagnosed after reproductive years. However, more and more women are currently pursuing pregnancy in their 30s and 40s, and pregnancy is becoming more common in scleroderma. So our data are becoming more available and also, fortunately, reassuring. So I'd like to start with fertility. So early studies in the 1950s showed lower birth rates among women with scleroderma, but in recent studies, there have been shown no difference in fertility between scleroderma and controls who do not have scleroderma. And multiple factors likely contributed to that difference in the birth rate in those earlier studies. So one, some people might be counseled to avoid pregnancy due to safety concerns. There are medications that might be used that might make someone not pursue pregnancy due to safety or compatibility with pregnancy. There are concerns for new organ involvement potentially or physical discomfort impacting intercourse. But a study done by Dr. Steen in the late 1990s found that the rate of infertility was really not significantly different compared to women with scleroderma, rheumatoid arthritis, or without an autoimmune condition or a healthy control. So the rate in this study found 15% infertility, which is defined by an ability to become pregnant despite regular intercourse for 12 months. So actually quite a long period of time. So 15% in scleroderma compared to 12 in rheumatoid arthritis and 13% in controls. And this difference wasn't statistically significant, meaning that those small percentage points differences are likely due to chance alone. And then they looked at the pregnancy rate for people who were initially found to have issues with fertility and ultimately becoming pregnant. And they found that 37% of people with scleroderma eventually went on to have a successful pregnancy after having been evaluated for infertility, compared to 40% of rheumatoid arthritis and 43% in controls. And again, those small percentage points difference was found not to be statistically significant. So the good news is that fertility seems to be similar in controls and other autoimmune conditions. And so for that reason, it is important to use a highly effective birth control method when you are not hoping to be pregnant. So I want to know when the time is right to plan ahead. And it's important to know that some medications, including the medication mycophenolate or Cellcept, may interact with birth control. So when we talk about using a highly effective birth control method, we're often meaning an IUD or two forms of birth control, like an oral contraceptive pill as well as a condom. Though the interaction between Cellcept and the birth control may be more theoretical, it's important to be very diligent and safe. And again, the IUD is the most reliable form. And then also we have data showing that assisted reproductive technology, including in vitro fertilization, is safe for women with autoimmune conditions. And so if there are issues with fertility, this is an option that can be discussed as well. So pre-pregnancy planning questions. So a couple of things we want to talk about. When is pregnancy safest in scleroderma? Are my medications safe for pregnancy? And do I need any testing prior to becoming pregnant? So first, pregnancy timing. So it used to be that most physicians were suggesting that we wait at least around 3 years after the diagnosis was made. And that's generally 3 years of disease duration. So 3 years since the first symptom that wasn't Raynaud that your doctor's attributing to scleroderma. And the reason was because the disease may be more unpredictable during those first earliest years, but there's really not a lot of data to support this at all. And recently we're really focusing on individualizing this to the patient. So what risk factors does someone have for different organ involvement? How are things looking now? But it is important to know that if there is a case of, you're having early rapid changes in your scleroderma symptoms, we might recommend that you delay pregnancy until symptoms are a bit more stable. And so our goal for pregnancy timing is to have stable scleroderma symptoms that are well controlled on pregnancy compatible medications for about 6 months prior to getting pregnant. So if all the medications that you're taking are safe for pregnancy and scleroderma has been pretty stable, you're feeling well for about 6 months, that's sort of the ideal situation. So let's talk about those medications. So some medications are recommended to be stopped at least 3 to 6 months prior to becoming pregnant. So medications like methotrexate, mycophenolate, cyclophosphamide, rituximab, tocilizumab, for example. And so for this reason, it really is never too soon to start talking pregnancy planning with your doctor. So if you think that it might be something that might be of interest in like years ahead, it's still good to have this on your horizon to switch over to medications that we can use during pregnancy, make sure things are stable. It's always easier to kind of accomplish this when we have more time, and also safer. So let's talk about some of the medications that we do not continue during pregnancy that are commonly used in scleroderma. So these can cause issues with birth defects. So mycophenolate, which is also called Cellcept or Myfortic, methotrexate, cyclophosphamide, these we recommend discontinuing at least 3 months prior to pregnancy. And I also note that cyclophosphamide can impact fertility as well. With ACE inhibitors and angiotensin receptor blockers like losartan, we recommend stopping those as well, but not quite as far in advance. We have a little bit more flexibility. And so another kind of note is that when taking these medications, we do really want those highly effective birth control methods to be used so that we don't have those issues coming up, and also we're planning ahead. So these are some examples of medications that can be used during pregnancy. So low doses of aspirin often are used, sometimes recommended. Tylenol, hydroxychloroquine, IVIG can be continued in pregnancy. Azathioprine, sildenafil, especially if we're using it for pulmonary hypertension, the risks really will outweigh the benefits will outweigh the risks there. And then calcium channel blockers like nifedipine can also be used. And a few other medications. So non-TNF inhibitor biologics, we generally say to avoid, but there's limited data. And if the disease is high risk, sometimes we continue. With rituximab, the American College of Obstetrics and Gynecology recommend that we stop that 6 months prior to pregnancy, and tocilizumab 3 months prior to pregnancy. When it comes to NSAIDs, and then I'm talking Advil, ibuprofen, Aleve, naproxen, those types of medications that some people take for pain, others avoid because of worsening reflux or GI symptoms. We recommend stopping in case there's any difficulty in conceiving. It actually has a mechanism that may disrupt some of the processes of fertility, so it can lead to very transient infertility that results when you stop them. So if someone's having trouble and they are on those medications, we'll recommend stopping them. And there is a possible increased risk of spontaneous abortion on these medications. Those study results are mixed. So often these medications are not used during pregnancy, and they definitely are recommended to avoid after 20 weeks because there is association with a lower amniotic fluid or premature closure of the ductus arteriosus, is just one of the blood vessels that are important in the fetal development. So pre-pregnancy testing in scleroderma. So it's really important, and I mentioned that we want to make sure that the scleroderma has been stable for at least 6 months. We want to make sure that we're testing everything and making sure that we know that things are stable. And so often what we want to do is beyond just asking questions in the office, but doing a few tests to make sure that things are looking good. So the most important testing is really the cardiopulmonary system. So one is pulmonary arterial hypertension. So that's when the blood pressure in the lung system is higher. And, we can test for blood pressure in the body very easily with a blood pressure cuff, but there are actually two circuits of pressure in the body, one through the body and the second through the lungs, where the blood actually gets oxygenated. And the only way to really know the blood pressure in that lung system is to check with the echo. And that can give us an estimate of those pressures. And if anything is on borderline or there's any uncertainty, a right heart catheterization where the cardiologists go in with the device can measure these pressures very directly and accurately, so that we know precisely if there's any concerns about blood pressure in that system. And pulmonary hypertension really is a high risk feature of scleroderma in general, and certainly higher risk during pregnancy, because pregnancy increases circulating blood volume and just puts extra pressure on your heart system. Yes? I don't have if you have pulmonary hypertension before pregnancy. So that's a great question. The question was whether pulmonary hypertension is more risky as a disease feature going into pregnancy, or if pregnancy itself increases the risk of developing pulmonary hypertension. And so I mean the former. So if you already have pulmonary hypertension and you become pregnant, it's a little harder on your body to kind of manage that. So interstitial lung disease evaluation is also important. Pregnancy is associated again with increased blood volume and sometimes anemia. And, people tend to develop some degree of shortness of breath from pregnancy as well. So your lung function is going to be important to know about. So we certainly will do a pulmonary function test and sometimes chest CTs as well to get a good picture of anything going on in the lungs. So there are also a few lab tests that are important in patients with scleroderma. So the two antibodies, SSA and SSB, can be positive in some people with scleroderma. Classically, they're associated with Sjogren's and sometimes also with lupus. But in some cases, women with scleroderma will also have these antibodies. And there is a low risk of women with these antibodies of something called fetal heart block, which impacts the conduction system of the heart. And that risk is about 2%. So we recommend that if those antibodies are positive, that our obstetric colleagues are doing special echocardiograms for the baby in order to test for this. There's also a small risk of neonatal lupus rash, about 10%, and that also can be associated with somewhat low platelets. These things resolve, but it's good to know in advance so that you're prepared. Kidney function is also important to assess as well. Usually this is done in kind of your usual blood test with your doctor, but it's important to check before pregnancy as well, just because, like I mentioned, that total circulating blood volume can put some strain on the kidney. And then we want to check hemoglobin and your complete blood count, because anemia can be common in scleroderma, especially if there's any history of GI bleeding. And anemia also tends to be more common in pregnancy. So does scleroderma worsen during pregnancy? Is another common question that we're asked. So first, I just want to say that pregnancy and scleroderma have some overlapping symptoms, and there are certain normal physiologic changes that occur during pregnancy that could be a little bit more difficult in someone with scleroderma depending on how their symptoms are. So one, I mentioned the increased circulating blood volume. That's to make sure that you're delivering everything that's needed to the baby. And that can make things a little bit more tricky with pulmonary hypertension because your heart has to process all of that increased volume. And it also can make scleroderma renal disease a little harder because you're processing the volume and peeing out any excess, and that can be more tricky and lead to a little bit more volume retention. Some women get some degree of swelling in their hands, their feet. If there's also any renal disease and you're not peeing out everything that you need to, that can be made worse. I mentioned anemia, iron deficiency. This can also occur in pregnancy. Part of that is delusional because you do have more volume circulating around, and then part of that is a natural part of pregnancy. And this can be a little bit more challenging if you have a history of GI bleeding, like gave. So it's important, if that's the case, that you're kind of seen by your GI doctor and you kind of keep that doctor in the loop as well. And speaking of GI, heartburn during pregnancy is more common due to increased pressure in the abdomen. And that can push up on the stomach, and that can reflux the acid into the esophagus. And that also can be made worse in people who have already heartburn due to scleroderma. So when I mention, planning ahead, speaking with your doctors, I don't just mean your rheumatologist. So if you have a GI doctor, they should be, put in the loop when it comes to your pregnancy planning. If you have a cardiologist, a renal doctor, a lung doctor, everyone should be kind of informed. And so shortness of breath, in the first trimester, you can see some increase in shortness of breath due to elevated progesterone levels that just make you breathe faster, and you can perceive more shortness of breath. Later in third trimester, as the baby's kind of pushing up on your stomach and diaphragm, that can make you feel more short of breath as well. And this can be harder if you have lung fibrosis or pulmonary hypertension. But does scleroderma itself worsen during pregnancy? So multiple studies have shown that scleroderma tends to remain stable for the vast majority of women who become pregnant. But there is some risk that after pregnancy, there can be a flare. About 15% in one study had some degree of worsening skin fibrosis that was thought to be likely multifactorial and not just related to being postpartum or the pregnancy physiology state. But again, that means 85% of people had no worsening after pregnancy. And again, the most people have stable symptoms during pregnancy, which is good, especially if we're kind of coming off on some of the usual medications. And another good piece of news is that Raynaud tends to improve during pregnancy, and that's due to vasodilation. So you're trying to kind of get blood flow all throughout the body, including to the uterus and placenta. And that is a process that really opens up blood vessels, which is great for Raynaud, where usually those blood vessels are spasming and shutting and getting smaller. So often, while we can use medications like nifedipine in our calcium channel blocker type medications during pregnancy for Raynaud, that might be a reason to be on it. You may not need it because Raynaud tends to get much better. There are some studies too that not only is Raynaud symptomatically better, but there are fewer incidences of digital ulcers during pregnancy, which is also good news. Heartburn, though, tends to worsen. Again, patients who are pregnant tend to have more heartburn, and that's true in scleroderma, especially if there's pre-existing heartburn. So that can get worse. There's a little evidence that small bowel intestinal overgrowth can get worse during pregnancy as well. So that's kind of when your gut motility is a little slower. There's more time for the bacteria in the gut to flourish, and that can cause bloating, upset stomach, diarrhea. So if you're experiencing those symptoms, again, touch base with your GI doctor to get tested for that. And like I said, some symptoms just of pregnancy might mimic scleroderma symptoms I didn't mention in my table, but fatigue for sure is part of pregnancy, some muscle aches, things like that we can also see. So I do want to talk about pulmonary hypertension. This is probably the most important facet to be evaluated for, and to really have thorough discussions with your rheumatologist and your pulmonologist if you have pulmonary hypertension. So again, that increased blood volume places demand on the heart. And because of this, there is a risk of death. There was a study in 2009 of people with pulmonary arterial hypertension due to any cause There was only a couple patients with scleroderma in it, so it's not necessarily easy to generalize. We don't know exactly how kind of severity of pulmonary hypertension or the treatments you're on might impact it, but the mortality rate in that study was up to 33% during pregnancy. And that includes a higher rate during the 1 month postpartum period. However, there have been other studies subsequently that actually has showed good outcomes in patients if using a multidisciplinary team-based approach. And so if you were to become pregnant, that really discussion has to be had on a very, very individualized level. But close follow-up is needed during pregnancy, but also during that 1 month postpartum period. And I know it's very easy after the baby is out to be focused on the baby. But we really need to make sure that the woman or you need to kind of take care of yourself, monitor blood pressures, be seen frequently by the doctors, and obviously take care of that baby, but take care of yourself and be monitored very closely. So also renal crisis. So there have been reports of people with scleroderma having renal crisis for the first time during pregnancy, and that rate is about 2%, so relatively low. If it were to occur, it tends to be between week 16 and 28 of gestation. And overall, there have been other studies really showing that while we are seeing that there's a 2% chance of patients developing renal crisis, that really isn't higher in pregnant versus non-pregnant people. And one important thing to note is that it might mimic preeclampsia, which is a kind of later stage problem in pregnancy associated with increased blood pressure, sometimes swelling of the legs, protein in the urine, that can be severe if it develops into eclampsia. And so normal pregnancy symptoms also can mimic renal crisis. I mentioned swelling of the feet, some shortness of breath, some nausea. So these things are important to be aware of. Our guideline in the American College of Rheumatology recommends that we still use the medications, the ACE inhibitors, for people who develop renal crisis, even though it was on the list of medications I said we typically avoid. It's certainly going to be a discussion between a person with renal crisis who's pregnant and their doctor. But in most cases, we think that the risk of renal crisis, not just to the mother, but also the baby, is important enough to use these medications, though there may be some issues with birth defects. And it also depends a lot on what stage of the pregnancy we are in. So pregnancy outcomes. So although the majority of women with scleroderma tend to have successful pregnancies, there may be increased risk of some adverse pregnancy complications. And this is really true across autoimmune diseases, including lupus, Sjogren's, and others. There is a slight risk of earlier delivery, small for gestational age baby, intrauterine growth restriction, and miscarriage. But most of the studies that looked at this didn't account fully for other effects like age or medications that someone might be on and other risk factors. So it's hard to know the exact amount of risk this is, but it's probably slightly increased. And steroid use is a bit more associated with preterm deliveries. Often we try to be off of steroids going into pregnancy, but if you were to be on it, there could be a slightly higher risk of preterm delivery. Whereas people who are on folic acid, which is a B vitamin included in your prenatal, tend to have lower risk of preterm delivery, and those with the anti-SCL70 antibody in one study also were shown to have lower risk. So again, I've mentioned this before, this is really kind of an individualized risk assessment. And a lot of these studies and a lot of these assessments are sort of in a global kind of group where there can be nuances between individuals and their risk. But one important thing to note is that pregnant women with scleroderma should really be followed by high-risk OB, which is the maternal fetal medicine doctor. You may have an obstetric doctor who you're seeing prior to pregnancy or as you're trying to get pregnant. But the MFM doctors are the ones who are going to be much more aware of medical problems when it comes to pregnancy and be a little bit kind of more in communication with your rheumatologist and doing all the necessary tests. So this is key. And often people can establish with an MFM doctor as they're trying to get pregnant in order to kind of get that relationship going. And if you're interested in that, please talk to a rheumatologist who will help you. And so I did mention that outcomes to babies born to mothers with scleroderma have generally been positive, and some of the outcomes that we measure have been improving over time. So there's a large nationwide study that was published in 2023, so just last year, that showed the risk of fetal death in scleroderma pregnancies dramatically decreased in the 20 years previously. So this is great news, and it's probably due to better treatment options, appropriate planning. The OB doctors are kind of better identifying high-risk patients, better cooperation and coordination between rheumatologists and obstetrics, which is really important. And I can't emphasize the planning piece enough. Having, like I said, scleroderma in a stable place on pregnancy compatible medications can go a long way in making sure things go smoothly. So a word about miscarriage. There have been multiple studies, but not all studies have suggested that women with scleroderma may have a slight increased risk of miscarriage compared to the general population. And these risks may be associated with certain antibodies called antiphospholipid antibodies that can be present in some women with scleroderma. These antibodies are associated with preeclampsia and miscarriage in the obstetric realm. They can also be associated with blood clots. There are people who have antiphospholipid antibody syndrome that is completely on its own, but sometimes these antibodies can be present in people with other autoimmune conditions, including scleroderma. So it is important to have those known, the status of that known as well as you're trying to get pregnant. Usually the OB doctors will check it as part of their workup in somebody who is having any difficulties or having frequent miscarriages. And then being on pregnancy compatible medications with well-controlled scleroderma will also likely lower this risk. Monitoring during pregnancy is also going to help us with outcomes. So I mentioned those SSA and SSB antibodies. If those are positive, the pediatric cardiologists will do fetal echoes. So looking actually at the heartbeat in lots and lots of detail of the baby between 16 and 25 weeks. And that is a separate scan. They usually do around 20 weeks of fetal anatomy scan, counting all the fingers and toes and all those things. And they look at the heart, but this is a separate study that will really be almost the same amount of time only on the heart as the organ. And they're looking at the development and also how the beating is occurring, because there is an association with those two antibodies with that issue called heart block, which is a conduction problem where the top of the heart and the bottom of the heart are sort of acting on their own. Fluid and fetal activity monitoring may be recommended. So I mentioned the slightly increased risk potentially of intrauterine growth restriction. So measuring kind of the growth of the baby is important, and watching kind of how things go over time is the kind of percentile that that baby is in, kind of maintaining throughout the pregnancy, even if it's low or high or whatever it is, as long as it kind of stays on track, that makes everyone happy. If there's any drop in that kind of percentile, they'll be watching more closely, monitoring more closely. And that's true also for the amount of amniotic fluid. And so the OB will be monitoring the baby size and growth. And then we want to make sure that we're on top of blood pressure checks. So women with RNA polymerase 3 should be checking their blood pressure at home anyways, due to slight increased risk of renal crisis in that group. All patients with scleroderma could benefit from regular blood pressure checks too, and that is all the more true during pregnancy, especially after week 20 when preeclampsia is possible, but also throughout pregnancy in order to monitor for renal crisis, which is associated with sort of a sudden increase in blood pressure and decrease in renal function. So most, let's talk about delivery. Most women with scleroderma can have a vaginal delivery. So having scleroderma itself doesn't mean you have to have a cesarean section. And it's actually preferred to have a vaginal delivery if the baby's doing well and there aren't any severe contractures that's limiting kind of getting into the birthing positioning. There have been a few reports of some cervical skin involvement that has made it difficult to deliver through the cervix. but this is really rare. I would also encourage everyone to kind of advocate for themselves, but also ask their doctor to help with this, but making sure their room is warm. The last thing you need is to have Raynaud attack as you're trying to deliver, and then monitor the blood pressure closely after delivery. So again, sometimes it feels like the baby's out and then everyone kind of shifts their focus, which is good. It's important. There needs to be doctors focused on the baby, but also there needs to be doctors focusing on you, watching your blood pressure. The after delivery period can also be a time where blood pressure can be high and things can happen. So it needs to be that everyone's paying close attention. And depending on kind of where you are and what your hospital is, the doctors there may or may not be as familiar with this need. Okay, so breastfeeding. Um, so one is medication. So it's really important to weigh the risk of the medications versus the benefit of breastfeeding. And this is really kind of a personal decision. So it depends on how your scleroderma is and if things have been very stable and you've been feeling quite well, and there isn't an urgent kind of need to restart your cell sept, for example, you may choose to breastfeed for some amount of time prior to resuming your medications. But often there are medications that can be used during breastfeeding that were avoided during pregnancy. And that's because drug transfer to milk is not the same as drug transfer through the placenta. There's also some options for timing of feeding. So, you might take your medicine in the morning and wait a certain amount of time before breastfeeding. And there are sometimes recommended, or people might try exclusive versus partial breastfeeding. And the age of the infant also impacts how well the baby might be able to, metabolize sort of microscopic or kind of small amounts of drug that go through the breast milk. And so all of this there's lots of nuances here. So definitely check with your doctor about all of your medications, whether they're compatible with breastfeeding, if that's something that you're interested in. But also breastfeeding, sometimes Raynaud can involve the nipples. This isn't particularly common, but it has been reported and some patients do experience that. So keeping warm the room, keeping your breast warm, especially as you're trying to maybe do some skin to skin time with your baby. You can use calcium channel blockers or Raynaud that obviously helps the hands and the feet, but can also help if there's any kind of nipple involvement that's making breastfeeding a challenge. So last I want to talk briefly about men as well. So fertility in men with scleroderma, there are really few studies that have evaluated this, but erectile dysfunction can be more common in men with scleroderma and can impact intercourse. And then there's some medications that can decrease fertility in men that can be used occasionally, typically are reversible. The one exception would be cyclophosphamide, which can cause low sperm counts that is not necessarily reversible. So sometimes before starting cyclophosphamide, there is kind of options to cryopreserve semen. However, this medication, cyclophosphamide, generally is being kind of used less and less in scleroderma as we have better, kind of more safer options. So in summary, so it is never too early to discuss pregnancy planning with your rheumatologist. And I would also add your GI doctor, your heart doctor, your lung doctor, your primary care doctor. Everyone that's part of your team should know sort of what are your reproductive goals. There's never like a time too soon if you're thinking maybe in the next few years, even, the last thing you really want is to say, I'd like to get pregnant now. I should probably mention this to my doctor. The sooner the better. Everyone is able to kind of get on the same page, get those medications aligned, optimize everything that we can when it comes specifically to pregnancy and scleroderma. And then I also can't emphasize enough that your preconception planning should really be tailored to you as an individual. So how are you feeling? How bad is the scleroderma? What stage are you in? Is it very early? Have things been changing with your pulmonary function over time? Or are things very stable and you've had scleroderma for a few years and you're feeling well and you're thinking that you may not even need the mycophenolate that you're taking. So everything is should be tailored to you as an individual. And it can involve your rheumatologist, but it also can involve other doctors. Even making sure you're up to date on vaccines with your primary care doctor is also important. So timing and medication management is really essential for ensuring good outcomes. Of course, there are people who have gotten pregnant on non-pregnancy safe medications and have had fine outcomes, but if we can avoid that, we always want to. So making sure that the medications that you're on are safe during pregnancy is certainly helpful when it comes to ensuring that outcomes are good. So women with scleroderma often have uncomplicated pregnancies and deliver healthy babies. So this is a good news. I think there was a period of time, especially when I mentioned fertility, low birth rates from those 1950 studies, where physicians who just didn't really know much about scleroderma, we didn't know about the outcomes, maybe were recommending against pregnancy altogether. And we're finding as more and more people are getting pregnant and having healthy babies, we're learning so much more from our patients. And people overwhelmingly tend to have uncomplicated pregnancy. Those risks of the kind of conditions that I mentioned are somewhat higher. These are still in sort of the range of like 10% or less. So people are overall doing well. And the also good news is that scleroderma is likely to remain stable during pregnancy. Pregnancy is usually a time of sort of immune tolerance as you're growing a baby. Your immune system, you don't want to be really too upset about something that's not you being grown in the body. So often some, but not all, autoimmune problems can sort of get better during pregnancy, and scleroderma tends to remain stable. And then Raynaud generally improves, and this can really be a marked improvement. But the GI symptoms may worsen slightly, so make sure to kind of talk to us about those things. And then I mentioned all women with scleroderma should really be followed by a high-risk OB, the maternal fetal medicine doctor, and also your rheumatologist really closely. And lastly, assisted reproductive technology is an option for patients with scleroderma. So not just IVF, which is when the sperm and egg are fertilized outside after retrieving eggs, but also intrauterine insemination and other techniques that are available are considered safe and an option for people with scleroderma should there be any issues with fertility. So make sure to keep that in mind. So a couple key references here that I cited. I'd like to kind of point out specifically the ACR 2020 guideline and Lisa Samaritano, the first author who went through these slides with me very graciously to make sure that I have the best data to present to you today. And then thank you to everyone at HSS, our Scleroderma Center. Anyone in the tri-state area wants to visit us, you can give us a call. This is our number. We also have options for fast track appointments. We try to get people in for the first time in a few weeks if you're willing to come in person. So we have some time now for questions or comments. And then I also want to open it up if anyone wants to kind of talk about their experiences, educate me or anyone else. So thank you.